exclusively for the Egyptian Venous Forum 2022. I'm proud to present on endovenous ablation of the saphenofemoral junction. I have no disclosures. You will know from my background that personally I'm fighting for the evolution in venous therapy, in particular about preferring vein healing to vein killing. And I do this in collaboration with a non-profit organization called the Leading Vein Clinics of the World. Together, we are doing lots of research to improve all our current strategy, and I hope you will enjoy this talk. When we are talking about GSV ablation, we are well aware that thermal ablation has the danger of creating e-heat. So many of us prefer to start the ablation below the epigastric vein level. When we do venous gluing, of course, we have to avoid the propagation of glue to the deep venous system, and that's the reason why all the manufacturers recommend to keep some distance of 2 to 7 centimeters to the junction. And concerning all these different kinds of foam ablation, we are aware that there is always the danger of foam particles or even larger amounts escaping through the saphenous junction, creating deep vein thrombosis, and that's another reason to maybe keep some distance to the junctional level. I would like now to introduce you to some general rules of optimal endovenous therapy, and it starts with the determination of the true origin of the disease, meaning the exact valvular status concerning closure defects, damage on certain parts of the leaflets, and so on. Second, we need to know the status of the different valves involved in the region of interest. Third, we should not stop our examination exactly in the region of interest, but go a little further to check the surrounding to estimate potential hemodynamic interactions. The rest of it is therapy. I would like to stress the necessity to establish a laminar flow for the prevention of recurrences. This illustration shows you how things appear in people's lives, starting with the congenital embryonic valvular lesions. Half of our kids already have them in different quantity and quality. Years later, we observe pressure-induced valvular decompensations, and finally, even some years later, there is a third kind of, in this case, valvular destruction, most probably by inflammatory procedures, starting with the accumulation of blood cell accumulates in the valvular region. So any one of these three mechanisms could be relevant for the disease of the saphenofemoral junction. And the first letter of these mechanisms, embryonic, pressure-induced, stasis-related, resulted in the idea of giving EPS name to this brand new classification of valvular lesions. Now, if pressure-induced damage should be present in the pre-terminal or terminal valve, you have to think about the reason for that. And most probably, it's if it's asymmetric and it's just related to one side, there might be the situation of missing or diseased iliacofemoral valves. So you will not be able to provide a real solution. You cannot heal the origin of the disease being venous hypertonus. So in this case, I think it's highly important to protect all the other branches of the femoral junction from this hypertension. In other cases, it might be different. If you have congenital or acquired lesions by stasis, there is no other reason around, and your treatment of very lesion location might properly fix the problem. So we have to go for the real origin of the disease. Second, of course, we as a standard will evaluate all the branches around the junction for reflux or for any hemodynamic abnormalities. Many of these factors are quite new, as we should also look for local valves which are not yet decompensated or disrupted, but show some signs of pre-reflux changes. So we should take that also into account to prevent early recurrences. In particular, I would like to emphasize the value of this publication of Sergio Giannassini among many other mechanisms for recurrences around the SFJ. He pointed to missing or damaged iliacofemoral valves, which should properly check in every case before deciding about leaving a stump or not. So if there is increased iliacofemoral hypertension, it's very probable that as this cause will persist, we have a higher incidence of SFJ recurrences, and in particular AHGSV insufficiencies, when we do not protect all the branches from hypertension by doing closure from femoral level. So I would say that all failures, recurrences, and complications occurring around the SFJ are due to suboptimal analysis or suboptimal techniques. As an example, we did a little study years ago in more than 8,500 cases, observing them in short intervals after intervention for the existence of EHIT, and with the technique we applied, we did not see a single case. So we went for another study, and this was to compare in two similar groups of 120 patients each. Group A starting ablation from femoral level, so-called laser crossectomy, which it isn't. It's just, in the best case, a sphenectomy. And Group B starting ablation below the epigastric vein level. And you can see that by estimation of the anatomy, by starting at femoral level, almost every case had the AHGSV well covered. And when doing the laser below epigastric level, just very few cases had the entry of the AHGSV properly covered. And so it's not surprising that after 2 years, we see a low rate of AHGSV, a newly appearing disease, while in Group B, when laser started to reach out the AHGSV covered, we see a 5-fold increased rate of newly onset AHGSV insufficiency. So there are many reasons to differentiate the cases and the situation. And if you think there is any reason for pressure protection or prevention of AHGSV disease, if it's not diseased at the time you do your GSV therapy, I can really recommend to start from femoral level and to take care to properly cover all the space to the venous femoral wall with your tumescent fluid and do a perfect compression of your target vein. And in this case, you will not see any complications, and in particular, no ear hit. These final pictures show typical situations after different techniques of ablation, and of course the cases with a longer or shorter stump do not represent laminar flow, while a proper closure at femoral level would do so. And of course this is highly favorable in terms of prevention of recurrences. If you cannot achieve laminar flow with the means you have at hand, you might consider to add some hyaluronic gel to fix your target vessels to the desired size. And this is a new method and actually a topic of different talk another time, another year, to show you how we can influence recurrence rates by this additional optional tiny, short, clever treatment. So I come to the conclusions, and let me state that laser ablation of the GSV from femoral level is highly effective in preventing future AGSV or other branches reflux compared to modalities leaving any stumps. This was known and true for surgery. It seems slightly less important for the endovenous therapy, as we do not apply that much local force and there's not that much damage, but the principle remains, as any local pressure will have some propagation to the local branches. Second, a procedure like this will prevent recurrences, in particular in case of increased iliacofemoral pressure. That makes quite sense. Third, the technique I showed to you, it's very simple, very safe, and very effective to prevent any complications like EHIT. And third, we should not just watch the local SFJ anatomy, but extend our examination at least to the iliacofemoral and AHSV valves to check for the real optimal strategy. So thank you very much for listening. It was a big fun to present, and I hope you have also a big fun to listen to this and the following talks and go for exciting discussions. Thanks a lot.
Thank